Welcome to this webinar. I'm Liz Stewart from Johns Hopkins Bloomberg School of Public Health. I am proud to be the co-director of the methods core for this ALACRITY Center, which I'll give you a little bit of background on. This is part of our series on advanced methods for mental health services research, which again, I'll tell you more about. So as I mentioned and implied, this methods webinar is part of a series hosted by the Johns Hopkins ALACRITY Center for Health and Longevity in Mental Illness. The ALACRITY Center overall is an NIMH-funded center, which is a research to practice translation center designed to address the wicked problem of premature mortality and medical comorbidity among people living with serious mental illness. You all are here today because as this webinar, which is part of our methods core. So the ALACRITY aims overall, just to give you a broader sense for the center as a whole. We're joined by Gail Dommett, the PI of the center today. So the aims, you can see the first three are kind of mental health services focused. So planning and testing implementation strategies and evidence-based interventions into community settings, and enhancing community partnerships, building capacity among mental health researchers and community partners to advance health for people with serious mental illness, and then advanced methods for implementing and scaling evidence-based interventions. So today's webinar is kind of in between the third and fourth bullets here, where we are aiming to disseminate methods related to, again, mental health services. The methods core also does does methodological advances that are related to mental health services. And I do want to give a flag for some previous webinars that we've done and recordings of those, which are available at this website. And I believe we'll put a link into the chat so you can see the full set of sessions. We've had one earlier this fall, and then our next one, actually, we'll also put a link in the chat, is March 26th, the same time of day, 10:30 to noon Eastern. And John Jackson from Johns Hopkins will be talking about causal decomposition analysis. So you can register right now for our next session. And we look forward to also, if you have any thoughts of additional topics that you'd like to see us covered, we welcome that feedback as well. But we hope it's useful. And the idea, again, is to really make these advanced methods more accessible, and especially those that are relevant for mental health services research. So I am happy to now turn things over to today's presenter, Carly Brantner. Carly is currently an assistant professor in the Department of Biostatistics and Bioinformatics at Duke University. But what makes Carly's presentation today particularly meaningful is she got involved in ALACRITY, and I think about 2018 when she was an undergrad at Hopkins. And so we've been thrilled to have Carly's engagement in the center, starting in her undergrad, continuing as she did her PhD in biostatistics with us at Johns Hopkins. I was proud to be her advisor. And now we continue to collaborate and work with her on sort of relevant topics. So again, it's, I think, particularly meaningful for, I'll speak for Gail and myself and others associated with ALACRITY, to have Carly now coming back to join us today to do this webinar. Just a moment of logistics. The presentation, Carly will sort of go straight through for about an hour or so till about 11:30. If you have questions, please do put them into the Q&A. You can also use the chat, but the Q&A is better. I will be monitoring those and might jump in with a question, but we're going to try to mostly hold the Q&A for the time at the end, or between about 11:30 and 12. And I didn't say this, but we're really lucky to have Carly because her topic is use of electronic health records, and she has a lot of expertise with this, as you'll see, and will help us understand some of the opportunities and then also some of the challenges. So we really welcome your engagement and your questions. We really want this to be relevant for all of you and helpful for all of you. So please do put questions in the chat, and or in the Q&A, and we'll turn to them after the presentation. So I will stop sharing and turn things over to Carly.
Awesome. Thanks, Liz. Thanks for the great intro. And thank you, Liz and Gail and everyone, for the invitation to be here. Can you see my full screen?
Yes, looks perfect.
Awesome. And thank you everyone who's attending online. Really, really excited to talk to you all today. Like Liz mentioned, it's a full circle moment for me having had my first exposure to research really ever through the ALACRITY Center. So it's really exciting to be back here and to be able to talk about how much I've learned over the years since that first experience, and specifically in the context of electronic health record data. And so I know some of these methods webinars might be very specifically focused on a particular type of kind of causal method or things like that. This one might be a little bit different in that we're focusing on EHR study design in general. And how do we, I'm calling it the art of EHR study design. So how do we work with the amazing potential that comes with electronic health records and think through a lot of different considerations about ways to make your study design as effective as possible to get to interesting research results. So I'll dive right in. I'll be building off of some experiences that I've had working with a variety of types of questions in EHR, ranging from causal questions, comparing medications effectiveness, to more descriptive summaries of how patients are experiencing the healthcare system, to some more recent work I'm doing now where we're looking at networks of electronic health record data, so such as PCORnet, which I'll be talking about towards the end. So, like I said, we'll dive right in, try to keep track of time. So since I titled this The Art of EHR Study Design, I started with a AI generated art piece. So EHR data, messy or a masterpiece. I'm starting with this kind of messy starting point where electronic health record data, like we know, has incredible promise, but it can be really hard to parse through. So we can see this Gemini generated visual. We've got all these colors, all these pieces of data coming together, but in a very abstract way. And it's really hard to think about what the true underlying picture might be. And so that might be where we're starting with a visual interpretation of what we're starting with electronic health record data. And with effective study design, hopefully we can turn the abstract art into a clear picture. So we see still the same colors and the same starting point, but now we've got this beautiful landscape, and we've gotten there through effectively designing our study and telling us what we're able to get from the data into an effective outcome and result. However, with the same data, different design decisions can change your picture. So that can range from how you defined your cohort to what outcomes you selected. All these different considerations can really change the ultimate result you get, the ultimate impact you're able to make. And so it's really important to be very careful and very thoughtful about the decisions that are being made with electronic health record data. And I don't have this shown visually, but also I wanted to mention that going from this messier abstract starting point to this more clear picture that you can interpret, that's not always guaranteed with EHR, and making some study design decisions that are less effective cannot be helpful in getting from this abstract piece to this more beautiful ending point. And so again, it's important to have these considerations in mind to do your best in a challenging situation to get from this starting point to this goal ending. And today we'll be talking about these types of effective study design decisions and the considerations. I'm not going to be giving a bunch of rules and kind of clear answers for how these decisions should be made, because there's often not a right answer. Like I mentioned, you can get different types of pictures, and the answers that can happen can vary across studies. So more really today, I want to focus on what you need to grapple with when you're working with this type of data. And I'm looking forward to the Q&A and discussion at the end to hear about the experiences that all of you have had in this space and questions that have come up. So I mentioned this already, but goals of today, discussing considerations for effective study design using electronic health records. I wanted to note that I'll be primarily focusing on using electronic health records in a retrospective way, so looking back at data over the past several years to conduct a retrospective observational study. A lot of the considerations I'll mention will be applicable to prospective work as well, though. And then I'll introduce a case study using electronic health records for comparative effectiveness research, and I'll tie back to that throughout. And that's been some work that I've done with Liz and others to look at electronic health records in the context of depression. And then I'll give some big picture guidance for decision making. Like I said, no right or wrong answers necessarily, but some general insights on what types of decisions can be made. All right, so I'll start with why conduct research using electronic health records. I think if many of you are here, you probably have thought through the answers to these questions. But I wanted to get us all on the same starting point, write something down here. So why electronic health record data? There are several pros. There are several reasons to use EHR. One is the amount of data. So we have potential for incredibly large samples, longitudinal follow-up, able to look at patient experiences over a long period of time from one or more healthcare systems. And so just the amount of data available is, of course, a definite pro. Additionally, EHR is often reflective of pragmatic real-world care. So we're not typically artificially introducing a decision. We're actually able to look at the data that represents what a provider and patient decided to do with that patient's healthcare journey. And so we're really seeing what's happening in reality, what prescriptions are looking like, what trajectories are looking like. EHR additionally includes potentially diverse patient populations. The goal is that we have this diversity in our samples, but it does depend on the particular healthcare system that you have access to, if it's just one. But there is this potential of a more diverse range of patients compared to some historical issues in representing different patient populations in clinical trials, for example. So that's another pro. Cost efficient, especially if you're looking retrospectively, you're not introducing new methods of data collection, you're not having to really worry about the high levels of cost that can come from other types of studies. And then potential for linkage to other sources. And that can range from claims data to pharmacy data, wearable devices, social determinants of health, geographic data. All of those things are possible to be linked with electronic health record data. So I want to be more general, not specifically focus on causal type of questions, but I will touch on this throughout, especially since our case study is meant to be causal. For causal questions, I wanted to just denote the difference between randomized control trials and electronic health record studies. And we have a paper that recently came out about this that I'll reference towards the end, where in the context of RCTs, where we might be traditionally thinking of as our more gold standard approach for causal inference, we have randomly assigned treatment. Versus in the electronic health record, as we know, we are looking at treatment assignment not randomly, but based on doctor and patient decision, particularly in this case where I'm thinking about retrospective study. We can handle the fact that there are going to be biases potentially or confounding involved in this treatment assignment, but it's reflective of what's really happening in practice. In RCTs, we have predefined study visits versus in EHR, we have variable encounters that are driven by the patient. So a lot more variability reflecting of how a patient's actually interacting with the healthcare system, which is great, but that can also mean that it's very hard to guarantee that someone's going to be coming to the healthcare system within your study period. My third point here, RCTs are of course prospective, and electronic health records, we can look in either direction. With RCTs, we often have strict eligibility criteria versus EHRs. We often have a broader patient sample, at least to start with. So we're not enrolling patients based on these restrictive criteria that are often found in RCTs. However, we can emulate them, which I'll come back to. In RCTs, we often have very specified measures that are collected in a very systematic way, periodically with preset time points. In EHR, we might have access to more measures based on what's being collected in the healthcare system, but we have more sporadic collection of those measures. And then our last point here, which is not the last, the list goes on, as I mentioned, but timing and reasons for dropout are often very of high interest and collected very specifically in a randomized control trial to ensure that we understand why patients might be leaving the study versus electronic health records. We often have no idea. Patients might be entering and exiting the healthcare system often. They might be jumping from one system to another, and we're not able to capture that if we only have access to one system. And so we kind of don't necessarily know why they dropped out or even if they dropped out. So that's a consideration we'll be talking about. I don't know if there was a question, but I think that was just a quick hand raise. All right, so I'll go into the case study now. And this will be something I'll be referring back to throughout as we go to mention kind of how the concepts I'm talking about relate to this particular case study. So again, this is work that I've done with Liz Stewart, funded by one of her grants, and it covered some of my PhD work, as well as some continuing work that we've been doing where we've looked at comparative effectiveness of duloxetine and vortioxetine for patients with depression at two large healthcare systems, specifically Johns Hopkins and Duke. And for a little bit of quick backstory, the reason why we're looking at duloxetine and vortioxetine, we're interested in comparative effectiveness specifically in the context of depression. We also were originally very interested in looking at both trials and electronic health record data. And we had some trials that compared these two medications in the trials, and we also had access in the EHR. So I'm just focusing on the EHR piece today, but that's some of the motivation behind these medications, and we're also interested in their comparative effectiveness. And so we're looking at an estimate of the average treatment effect comparing these two medications across a variety of outcomes. And these outcomes are listed here. They include everything from hospitalization to medication switch, suicidal encounter, and depression severity according to the patient health questionnaire that can be collected at routine healthcare visits. So we'll be coming back to this throughout. One more touch on RCT versus EHR data I wanted to highlight. We have, from this case study, I wanted to show some standardized mean differences for two types of cohorts. So we have the electronic health record cohort, specifically in Duke, and I'll be introducing that cohort in just a bit, compared to the cohort of patients who participated in the trials. And these are all patients who were receiving one of these two medications, whether it was actually at Duke or in a randomized controlled trial. And these standardized mean differences are measuring how far apart the two groups are in units of standard deviation. So what we can see here, this is comparing the electronic health record to the trials. And we can see that on the right-hand side means kind of higher in the electronic health record in standard deviation units. So the EHR cohort has, hopefully you all can see my mouse, heavier weight, lower baseline depression, so substantially lower in the electronic health record compared to the trials. And the trials actually restrict to ensure that the baseline depression is higher. We also see higher percent Black race and higher percent in the EHR with certain comorbidities as well as other medications. So that's not going to always be the case when comparing electronic health records and trials, but we can see, at least in this example, that the electronic health record participants might have more of these other conditions, kind of due to the fact that the trial is potentially more restrictive in recruitment. Okay, so I have now broken down the components of EHR study design into 7 key components. Very open to feedback and others' thoughts if there are more key components that I may be excluding here, but for the purposes and the length of this talk, I came up with 7 that I really wanted to touch on today. And we'll talk about considerations for each of these and potential kind of thoughts and decision making, and as well as how they affect our case study that I just mentioned. So we'll go through each of these in order, but we're ranging from specifying a research question, cohort construction, time, characterizing encounters and measuring variables, defining outcomes, leveraging text data, and then coordinating multi-site data and context across sites. So we'll start with specifying a research question. This is, of course, a consideration in every study, and I just wanted to mention it to really start us off with the EHR because there are several types of research questions that we can answer when we're using electronic health record data, and there are unique aspects of the EHR for each of these types of questions. And with EHR, we can answer descriptive type questions where, for example, what proportion of patients with depression are experiencing a gap in their healthcare. That's actually a whole other case study that I didn't have time for today, but that's a project we've worked on in the Johns Hopkins healthcare system. So with EHR, we can really look at kind of these care experiences. We also can answer inferential questions. So for example, causal type questions like, is duloxetine or vortioxetine more effective for patients with depression? And so again, these are 2 different depression medications. And the question is, are they more effective? Is one more effective than the other? Does their effectiveness vary across subgroups? These types of questions can be answered in a trial and have been looked at in trials, but they can also be answered in electronic health record data. I put under here target trial emulation. I believe you all have also had another methods webinar about target trial emulation, at least in certain contexts, maybe policy contexts. We won't be going too far into that, but a lot of the pieces I talk about today are relevant for this idea of if you wanted to do a randomized controlled trial, but you couldn't for feasibility or ethical reasons, how would you emulate this trial using, for example, electronic health record data? So that type of work could be used to answer this question in the EHR. Predictive questions as well. So which patients are most likely to drop out from psychiatric care? can be really helpful in the EHR when we have this long-term longitudinal data and we can look at patient outcomes as well as look back periods, prognostic questions like typical trajectories of PHQ-9 after starting antidepressants, um, and then operational. So are certain clinics more or less likely to document PHQ-9? And I'll just briefly mention, I know this is mostly a mental health crowd, and the mental health practitioners on this call will be more effective than me at discussing more of the clinical context, but I'll mention that duloxetine and vortioxetine, just wanted to highlight again, these are antidepressants and they have different mechanisms, but they're antidepressants that have been compared in trials and are used to treat depression, but can also be used for some other conditions, like duloxetine, for example, can be used to treat pain. And then PHQ-9 is a standard questionnaire that's patient reported about symptoms of depression. So just wanted to highlight that. So in our case study, tying this first component back, we're asking the question, among adults treated for depression at Duke and Johns Hopkins, how do duloxetine and vortioxetine differ in clinical outcomes in routine practice? So a comparative effectiveness question, and this emphasis on clinical outcomes in routine practice. So that's why we're going into the EHR to get at something more based on the real world routine practice compared to what we're able to get from a trial that's already been completed in these settings. Okay, so moving on to our second component here, which is constructing the cohort. All of these components I feel like could use multiple hours of conversation and often do, especially in the case study we mentioned. They take a long time to consider, but giving some brief overview to each. So I wanted to reference Lane Thomas here at Duke, who uses these ideas of clinical and contextual relevance. So for constructing a cohort, you're really trying to think about who in your study, who do you want to study? So what's your target population in mind? Who are all the people that you'd want to study for your particular research question? And then what's the best you can do in your EHR? So what's the best cohort you can define to represent the people that you want to study if you had kind of everyone that you possibly could study of interest. So that comes down to who is really clinically relevant and who is contextually relevant. And for example, clinical relevance can be conditions, contextual relevance can be kind of settings, so things like telehealth care, certain clinics, that kind of thing. And another type of consideration is the cohort focused on maybe incident cases of some prescription or some condition, more prevalent cases, or looking at people who are at risk. Those are a couple of different considerations as well. And then lastly on here, I have the level of control on the patient population. So ranging from a very restrictive cohort that's very controlled, you feel really confident in kind of the homogeneity of your cohort, to a much more flexible, broad cohort, which is where we start with the EHR with a lot of patients with a lot of different experiences. And when you're constructing your cohort, you're really trying to go along the spectrum and say, how much do I want to restrict my cohort to make sure it's exactly the people and the experiences I want to study, or do I want to make it really more flexible, broad, representative of a lot of different types of patients? So in our case study, our clinical and contextual relevant individuals were patients with depression who received duloxetine or vortioxetine prescription. So again, we're looking at the comparative effectiveness of these medications. We focused on incident individuals, meaning we want new prescriptions. So not necessarily a new case of depression, but we wanted to find their first time they got a prescription for either of these two medications to be able to look at their experiences. And then for this level of control in the patient population, that's something we really spent a long time thinking about. So I'm going to dive into that just in a little bit more detail. So this is our research question again. We're trying to look among adults treated for depression, how do these two medications differ in their clinical outcomes? So we can see here, this is a concert diagram for how we created our cohort. And I'm starting with the right-hand side of that. I'll go back real quick, this more flexible, broad situation. So when we start with a broad cohort, we're looking at patients with visits at a psychiatry department or primary care with a mood disorder diagnosis affiliated with that visit. And that's between 2014 to 2021. So we have this long time period, and we're looking at patients with these types of diagnoses. And you can see we're starting with over 100,000 or 150,000 patients. We then move towards patients who are 18 to 65 years old who had a prescription of either of our two comparator medications of interest. So we're making sure they got the medications, or they were prescribed at least the medications of interest. And then our last step here is patients with records 1 year prior to baseline and making sure that those records do not include either of these two medication prescriptions. And so what this is doing is first ensuring that patients came to the healthcare system in the year prior, and second, ensuring that to the best of our ability that these are, again, incident prescriptions of duloxetine or vortioxetine. So at least in the last year, to our knowledge, they did not receive either of these medications. So it's their first time, ideally. So we end up with almost 10,000 in both of our cohorts. So another flag that with the EHR, we're able to get this really large sample. And this is considered to be, we've called it kind of a broader cohort because we don't put a ton of restrictions. We're really just making sure they have a mood disorder and they have these medications ideally for the first time, and they've somewhat interacted with the healthcare system. Now, moving towards a slightly more narrow direction, one adaptation we've made is we've required, the only difference here is we've required that the prescription of these two medications happen at the same time as a depression ICD code. And so while this doesn't actually guarantee this, the assumption is that this means that most likely the medication was prescribed to them for the first time to be able to address depressive symptoms. And you can see if we compare the two slides, we've got about 14,000 down to about 6,000 when we require this. So that means that either a lot of people are getting these medications for other reasons, or they are getting them for the depression, but it might not be being logged in the same way. So that's kind of a first notice of some of the messiness that can be happening, or just the importance in making these types of decisions of how specific do you really want to be? Do you care about everyone getting these medications, even if it might be for something slightly different, or do you want to make sure it's done for depression? And then I also added this piece of narrower. So if we want to go even more narrow, we start with our same steps, and then we can add several other steps. And this is getting a bit towards the target trial emulation type world, in that we're really trying to focus on in this case, we're trying to mimic what the actual trials did. So we had, again, trials that compared these two medications. And when we do these extra restrictions here, where we ensure that they do not have a list of other mental health conditions like schizophrenia, we also make sure that they have a non-missing baseline PHQ-9 score. So around the time that they got their first prescription, we want to make sure that we have some indicator of depression severity using the PHQ-9 questionnaire. And then this last step is making sure that their baseline PHQ-9 is at least 14, which kind of mimics what our trials did, where they made sure that the baseline PHQ-9 in their trial, they measured it using a different questionnaire, but the baseline depression was at least moderate. And they typically do that to be able to look at people who are at higher levels of depression, and you can see a more noticeable effect, for example. So what this is doing is really getting similar to an actual trial, and you can see we end up with 619 patients from Duke, which is smaller and much more similar to numbers that we might see in a trial. And then in Hopkins, we did not have the PHQ-9 for this study, so we end up kind of not focusing on PHQ-9 in this particular group. So for the remaining slides, I'll be focusing on the results from the broad cohort, this first one that I talked about. But I wanted to highlight that these types of cohort decisions can really impact your numbers and can impact the particular population you're focusing on. So it's very important when you're describing cohorts to show, of course, diagrams like these, and to also really clarify why certain decisions were made. For example, this big decision of, do we want to make sure that there is a depression indicator at the same time as the prescription, or do we want to be more broad? So in the cohorts that I just mentioned, I just wanted to tie back to our first slide on this component, where our clinical eligibility was related to diagnosis, and depending on our cohort, with our narrower cohort, our last one, we also added restrictions on the level of severity at baseline and the level of other comorbidities. And then for contextual eligibility, we looked at medication prescription. And in our narrow cohort, we ensured that this prescription was actually aligned with a depression diagnosis. And then we also introduced look-back data. So this was looking at records in the 1 year prior to baseline. And what this was telling us was we wanted to first ensure some level of engagement in the healthcare system. So not just one person who came to Duke got a prescription and never came back again. Well, I'll come back to that, but came to Duke for the very first time and got a prescription. We wanted to make sure this was someone who had been to the hospital or the healthcare system before, and in the hopes that that would mean they're engaging more consistently. Another point here is to define baseline measures. So when we use the 1 year look back, we're able to look at things like, did they have other conditions, other medication histories, and then again to identify incident prescriptions to say they did not have a duloxetine or vortioxetine prescription in the year before our definition of them starting. And then this is another piece that could use entirely other talk, but computable phenotypes is kind of what I've been talking around a little bit. So the idea of computable phenotypes, many of you might have heard of these or worked on these types of algorithms, but they're meant for defining conditions, traits, or events in the EHR. And these types of algorithms and decisions on how you're really defining, for example, depression or a prescription or medication, those algorithm decisions can impact the cohort and impact the results. And so, for example, in our particular study, some ways to think about computable phenotypes, kind of very simplified down, are things like how many times do we need to see depression recorded? Does it need to be a primary or a secondary diagnosis? Do we need to have a prescription at the same time? Do we need to have a certain level of severity according to the PHQ-9? So those considerations, we focus on some of these later ones, but that can be involved in this space. And we also introduced PHQ-9 threshold for our most narrow cohort. All right, so that is cohorts. Now I'll move on towards establishing time, one of the other very, very meaty components in this list. So establishing time is very related to cohorts because I mentioned already things like a look back period, but wanted to show a few different important points of time in an EHR study, and this is in chronological order from looking back to time 0 to follow up. In trials, for a lot of the time, baseline is very obvious, where they're enrolled, they're randomized, they move forward. In EHRs, baseline is more of a design decision. And this idea of baseline or time 0, I'll start in the middle here and then go backwards and forwards. But time 0 is an index time point at which the study starts for an individual. And again, defining time 0 in the EHR is not as straightforward. So there's a lot of different options that I list some of them here. Time of first diagnosis or first prescription, for example, time where both are present, time that they had their first appointment that we could find in the healthcare system. If you're looking at more standard of care or placebo or more descriptive studies, time 0 can be especially challenging to define. In our particular case study, though, time 0 was defined to be the date that they got their first prescription of either of our two medications. So not necessarily understanding exactly what's happening outside of the context of this prescription. So what's happening when they're going home? Are they picking up the prescription? Those kinds of things. But we are looking at the first time we have a prescription record of either of these two medications. And that's because those are our exposures of interest. And in our narrow and narrower cohorts, we required that there was a depression diagnosis at the same encounter as the prescription. So that's how we define time 0 in our particular comparative effectiveness case study. Now, a look back period. I mentioned this already, but I wanted to reiterate within the context of establishing time. Look back period does several things. First, it can ensure stability and enrollment in the healthcare system. So in our case study, we didn't require a lot of engagement before our time 0. But in other studies, for example, if you really want to make sure they're coming very consistently, you can be very particular about this look back period and their behavior during it. It can also capture consistent amount of information per person. So although certain patients might be coming a lot to the healthcare system before time 0 and others might be coming less, at least if we look at a consistent amount of time for the look back period, we're ensuring that the amount of time that we're comparing across people is accurate. And then we can also use the look back period to define baseline measures, such as their prior trajectories, their comorbidities. In the past year, did they use these medications? That kind of thing can be really helpful to give us effective baseline information. And in our case study, mentioned this, but we have records 1 year prior to baseline, ensuring no prior prescription, and we're defining baseline measures like those that I just listed. So we're defining things like comorbidities and medications. Now for follow-up frequency is very challenging in the EHR because we're not requiring, unless we're doing a prospective study where we're actually interacting with patients, we're not doing anything to impact what follow-up frequency is for our different patients. And in fact, it might vary substantially by clinic site. Maybe there are some sites where the expectation is very consistent follow-up. Maybe there are others where it's not. Um, Follow-up frequency can also be influenced by both patient and practitioner characteristics. So I'll come back to this in just a second, but that's very related to follow-up frequency. And then also patients might seek care outside of the health system, or they might hop in and out, and that might be hard for us to be able to capture. And then the lack of follow-up reason might be unclear. So if we do not have clear follow-up happening, we don't know if that's because, for example, if our patient got duloxetine and then we never saw them again, maybe the patient had a great experience and they just never came back. Maybe they did not ever fill the prescription, did not want to take the medication. Maybe there's an access to care issue. All those things are really, really hard to tell. So that's important to keep in mind. And some bias risks do come up with follow-up, and I wanted to highlight these that first, this is leveraging the target trial emulation world. So this paper is a helpful reference where, especially if you're looking at a causal question, it's important that you use maybe more of the look back period to define patient engagement and define your cohort rather than defining your cohort based on follow-up. So if patients were to be excluded based on their follow-up behavior, that can induce bias. And instead, it's recommended that patients that you identify in some way or another to be lost to follow-up should be treated as censored. And this idea of loss to follow-up can depend on the study, but it might be that it's very clear they should be coming back within a year and they're not. That kind of thing can be implemented. And then another important bias is the idea of a mortal time bias, which can occur if your exposure can happen after follow-up begins. So it's really important that kind of time zero exposure, that's all happening before your follow-up time period, and that the cohort isn't really being selected based on things that are happening after your exposure. So in our case study, this is from the Duke patient cohort and this idea of the broad cohort that I defined early on. We're looking at follow-up in the psychiatry department. So what this is showing is the number and percentage of patients after they have their time zero or their first prescription, how long does it take them to come back for their first follow-up encounter within psychiatry? And so you can see very big bar here at the end where 70% of patients in this very broad cohort don't have any follow-up within 2 years in the psych department at Duke. And we had similar results in our Hopkins cohort, where we started to see a little bit less of an issue for this as if we were more restrictive in our cohort definition. But for this particular broad cohort, we're seeing a lot of people not come back. Our second biggest bar here is about 12% come back within a month. So we're seeing in the EHR, again, it's very hard to ensure that people are coming back. We might have a lot who are coming back consistently, and then we might have a really big sample who just don't come back at all. So that kind of thing can be very hard to control and adjust for. Couple of extra considerations with establishing time are just noticing the timing of data collection and the timing of data refresh. So I just wanted to mention these, that it's important to know when was the insurance, what part was the insurance associated with. For example, it was an inpatient stay. When was the insurance captured? PHQ-9, for example, a lot of times with appointments, maybe someone has asked the PHQ-9 in their MyChart, so maybe it's sent to them. And then the date of the recorded PHQ-9 doesn't match the date of an appointment. So that kind of thing can be really important to keep in mind. And that's something that's been a recent like learning for me as well, is how to match PHQ-9 with actual encounters. And when the demographics are occurring, and then when is data refresh happening. So when you pulled data once, is it going to change again when more information is updated about a particular encounter, for example? So that's just a couple of extra points about timing that I wanted to mention. So now moving to our fourth consideration, characterizing observation and measurement. So this one's also a pretty big one, and I have a lot of pieces to share here, and I'm excited to see others' thoughts and questions. When I talk about characterizing observation and measurement, that's really meant to be kind of a blanket term over what encounters are generating data, when are measures happening, when are measures missing, when is data observed, all of those different pieces. So I'll dive into those. So what types of encounters generate data? A lot. In the EHR, we have a lot of different types of encounters and maybe different sets of data to be pulling from to generate information that can range from what we probably typically think of as the most common, which is like a face-to-face visit. But then we also have all of these other visits. We have telehealth, we have prescriptions, we have inpatient encounters, we have labs, and all of these can generate different components of data. And these can be used to define a lot of different aspects of our study. So in our case study, we used all of these types of encounters, except not necessarily labs and procedures in this case. But you can see for all of these different encounters, we use them for a lot of pieces of our study design. So for example, when using face-to-face and telehealth visits, we use those in cohort definition. So trying to see, was there a depression diagnosis at those visits? Was there, and we're using them for covariates too. So looking backwards at previous visits, did they have these diagnoses? Did they have other factors associated with the encounters? You could also use them for outcomes too. And we did use them for outcomes too, but I'm bolding kind of the most common. Prescription encounters we used especially for cohort definition and exposure. So exposure particularly, did they get a duloxetine or a vortioxetine prescription? We also use them for cohort covariates and outcomes, so things like medication switch. And then inpatient encounters we also used for defining a cohort, defining covariates. Had they been hospitalized before? Had they been hospitalized for depression? Defining outcomes. Were they hospitalized later on after starting the medications? So all these types of encounters were really useful for getting a full picture in our case study. Now, characterizing observation and measurement, which encounters include key measures. So for example, if you're looking for something of interest, it's important to think about what clinics might it be measured in, what visit types might it be measured in, and these measurements can be dependent upon provider behavior and preferences and patient health. So particularly in our case study, PHQ-9 was our metric of interest. So we were really interested in looking at depression severity over time if we could. So PHQ-9 in our case would most likely be measured in psychiatry or in primary care in these types of appointments specifically. So there might be a lot of encounters that wouldn't really be worth looking at to see if PHQ-9 was measured or missing. And then this important point at the bottom saying that PHQ-9 being measured isn't just kind of a random thing. It can really depend on kind of site norms, clinic norms, provider behavior, and patient health status. So maybe someone who comes in and does not seem to have any indication of depression, they're unlikely to be asked the PHQ-9 unless it's a more standard of practice. So having all that in mind has been really important for us when we're looking at PHQ-9 and the idea of, is the missingness of PHQ-9 at random? Probably not, because it can depend upon all of these characteristics. So it's a fun missing data problem. When is data observed? So I made this visual to show that for data to happen in the EHR, there's a lot of steps that need to kind of be passed. So for example, if this person on the left, for them to be seen in the EHR, they first have to have access to healthcare. And so that can be in the form of all these little visuals that I added in. So can they get to an appointment? Does their provider have availability? Do they have insurance to cover the appointment, or can they afford the appointment out of pocket? Do they have a computer to be able to go on a telehealth appointment? Do they have Wi-Fi? So all those points can be addressed to say, does this person have access to healthcare? The next step is, are they seeking healthcare? So maybe they can get there, but are they actually seeking healthcare? And so that can depend upon a lot of factors as well. And some might be, are they feeling sick enough to want to go? So for example, our patients with depression who are getting duloxetine or vortioxetine, they might be more or less likely to seek care depending on how well or not well the medication is going. And also this other visual is meant to represent like how well has previous treatments worked for them. Do they feel like they can succeed if they get new treatments? And then this last point here is at the particular health system. So especially if you're only looking at one or two healthcare systems and their EHRs, for the data to be observed, the person had to go to that healthcare system, not another one that was close by or things like that. So all of those different pieces come down into this idea of observability or informed presence. So observability is the degree to which patient information is captured in the EHR, and it kind of reflects what I was just talking about in the last slide. And informed presence means that people don't just interact randomly with the healthcare system. So the fact that an outcome was observed or someone came to an appointment means they engaged with care, and the frequency means that it can depend on severity of their condition, access behavior, all the things that I just showed in that previous visual. And so, a gap in care, what does that mean? Keeping that in mind is really important. So in our case study, um, we addressed all of these different components in a lot of different ways. And one way being that we defined the cohort based on prior engagement with the healthcare system. So again, we didn't require a ton of previous behavior, but we made sure that they had been there before. So it wasn't just their first time. And ideally, that means they are seeking healthcare and they have access to the particular healthcare system that we're studying. Um, PHQ-9, this idea of a severity outcome, was not the only one we focused on because we acknowledged that when PHQ-9 was not observed, it's likely not just random. There's likely a reason behind that. So we kept that in mind. We did not use censoring, although we maybe could have. So the idea of if someone's lost a follow-up or they stop seeking care, we didn't go there. We only looked at 1 year follow-up and we decided not to focus on censoring, but something we could have done. And we also compared across our cohorts. So the idea of our broad, our more narrow cohorts, all those things, we looked at results across those. And so, sorry, just back to this slide. I know sometimes with EHR, it's easy to list a lot of challenges. And so these are examples of how we solved some of those challenges, or not necessarily solved, but at least addressed. Now, how is data measured? Wanted to mention this as well. It's important to keep in mind when you're looking at variable construction and characteristics and outcomes, understanding when something might be clinician or patient reported, understanding missing data. So I talked about observability. So this idea that missing doesn't necessarily mean unobserved. There's like a distinction there. But regardless, missing data can happen, and it's important to evaluate missingness assumptions. And then measurement error and lack of adjudication. So in a trial, while we might be really particular about adjudicating, like, is this diagnosis true? It's a lot quicker in the EHR. It's based on a provider's input and or a patient's input, and so measurement error can occur. So it's important to keep that in mind, the ideas of misclassification. So in our case study, PHQ-9 was self-rated, so it's important that we kept that in mind. It was patient-reported. And then we did have high levels of missing data. So we had over 70% missing in the Duke broad cohort, and that's why we ended up not using this as our primary outcome, and especially since we felt like the missingness was likely not just random. So what do we do? Again, trying to show some solutions here, some ideas on how to address this. Design strategies. So design strategies and analysis strategies can be used to address all of the different things that I just mentioned under characterizing these encounters and measuring characteristics. So in the column of design strategies, it's important to define what it means to be under observation. So for example, that can mean requiring previous engagement with the system. It can be having an expectation for what a reasonable amount of follow-up is, and if they're not meeting that, considering the idea of censoring. So if there are long gaps, choosing outcomes with observability in mind. So I mentioned this idea of observability, and it's good to prefer outcomes that are reliably captured when they occur. And the idea of symptom scale specifically in mental health or in other contexts are especially kind of to be used with caution because they're collected not randomly in the EHR. And it's good to supplement with other types of outcomes. Focusing on similar encounter type settings, et cetera, or at least characterizing those can also be really important. And then from an analysis perspective, using censoring when appropriate, conducting sensitivity analyses, which I'll highlight again at the end, and modeling things like visit frequency can all be implemented. Okay, so in our last 10 minutes or so, I'll go through the last three. Defining outcomes first. So defining outcomes, I broke down the outcomes into three types in healthcare: clinical status, safety, and utilization. If we think from a causal perspective, this idea of clinical status is kind of like an efficacy or effectiveness of a medication. So for example, PHQ-9. These are often sparse in EHR and can have informative missingness, so I've been mentioning these. Safety outcomes are also really helpful in the EHR, which can look at adverse events, harm, side effects, And EHR is really helpful for more rare long-term events. They could be misclassified, but they are really, really helpful for trying to say long-term, kind of outside the context of a trial where maybe someone's just taking a treatment for 1 or 2 months. What do we see in the long term with the EHR if they're taking something for years? And then utilization here is their interaction with the healthcare system, their appointments, their encounters. This is reliable in the EHR for the most part, and but the one challenge is it could occur in other healthcare systems. So, for example, if we're looking at a hospitalization outcome, that's typically logged reliably in the EHR, but it could be that when they got hospitalized, they were in another state or they were in another area and went to the closest hospital. And in our study, we looked at several outcomes. So again, we didn't just focus on PHQ-9, although that's what we had in mind based on the trials originally. We knew that we were going to be having to look at a lot of different types of outcomes. So we also looked at medication switch as a measure of clinical status as well as potentially safety. So if they were having side effects or issues with one medication. Any psychiatry encounter we measured as an outcome. So that's an outcome of utilization. And then we also looked at hospitalizations, emergency department visits, and suicidal encounters. So all of these metrics are different outcomes that could be selected in a mental health space, and we happen to look at all of them in our real case study. And so this is an example of just some of these outcomes and how much they were seen. So not necessarily actually showing the comparative effectiveness, but this is showing that, for example, for observed PHQ-9 score, what's the percentage of our cohort who had this observed at all? So about 50% didn't have any observed PHQ-9 score within 1 year post baseline and post time zero. If we look at some of these other types of encounters, so hospitalization for any reason, very high percentage of people did not have any hospitalizations after follow-up, but we do have some. And then similar with any psych encounter as well as suicidal ideation or encounter. And so we can see looking at a couple of different outcomes helps us explore the full picture and also address the fact that some of these are going to be more rare. Leveraging text data, our sixth consideration or component, that's something that really is unique to the EHR and is really helpful from the EHR. And especially with the advent of AI, LLMs, all these different things, there's really a lot that we can glean from the unstructured data that comes with EHR. So in our case study, we really focused on the structured data. And so I won't go into this a ton, but I really did want to mention that with clinical notes, there's more detailed information sometimes beyond the codes, prescriptions, and structured data, maybe something that can be supplemental, something that can give context to what's given in a structured format. And clinical notes can be leveraged from every step of what I've been going through, all those other components. Clinical notes can be used in defining cohorts, in defining covariates, in defining exposures and outcomes. So again, clinical notes is an area ripe for research and using them to inform the structured data and to kind of increase the reach of the study. I'll come back to that example in a second. Transcripts also. So at Duke, for example, we're using AI-generated transcripts when patients get permission. And so this goes a little bit beyond clinical notes and can add supplemental and potential more detail about fully what's going on in the context of a patient-provider encounter. And at least at Duke, some of these are very new, so I think there's a lot of work to still be done, but with the help of LLMs for both of these situations, there's a lot that we can glean. And so, for example, this is not in the context of mental health, but we're looking at Duke OB-GYN visits and trying to kind of classify patient-provider communication using these transcripts and see how we can use the transcripts to support some of these factors like defining cohorts and identifying people who maybe don't have a code, but according to their encounter could be relevant for our study. And then back to my example in the clinical notes piece, this is something related to our case study where we're using large language models to derive scores according to the CGIS from psychiatric notes in patients with depression and trying to see how AI-generated or LLM-generated scores match the scores of psychiatrists that are kind of auditing and going through these encounters as well. Okay, so now finishing up on our last component here, coordinating multi-site data. So there's a lot of different things that can be done to look beyond one site, and I'll go through each of these briefly. in our case study, we had a small number of sites. So we didn't have one, but we had two. We had Duke and we had Hopkins. And we used manual harmonization to be able to look at our results across both sites. We didn't share data across the two healthcare systems, but we replicated analyses in both and compared. And this requires a very collaborative, communicative team. A lot of code sharing, a lot of context sharing. So, for example, addressing discordant measures, maybe something is labeled one way at Duke, labeled another way at Hopkins, or Duke and Hopkins have different norms for how these different metrics are filled in. So all of that can be really helpful, as well as things like context sharing. So what do we expect our inpatient numbers to be at Duke versus Hopkins? So all that's been really helpful to see, and it allows us to compare results across the different settings, and it allows us to kind of see what similarities and what differences come up. And so keeping in mind all of these different components and all of these needs for code sharing effectively has been really important. And this last point here is keeping in mind state policy context for the health system. So that's true regardless of whether you have one, two, or many. Keeping in mind this more policy context has been really important as well. Another option is the federated learning world, where this is similar to really what we did in our case study, where we didn't share data across our sites, but you can use this idea of federated learning where you keep data privately across your different sites, and you fit local models and use those results to inform a more global model. So we didn't go as far as kind of integrating the results into a global model, but we did keep our data separate across our two institutions and fit the same models on each. And then lastly, I wanted to really mention these ideas of harmonized network data sources. So in our case study, we didn't use some of these larger scale harmonized networks, although Duke and Hopkins participate in some of these networks. But these networks like PCORnet are distributed networks where there are often common data models, and again, could use a whole other talk and happy to answer questions about some of these, but these provide EHR or similar data across multiple sites across the country. And so these can be used for large scale study. They have their own strengths and limitations. For example, maybe there's not the ability to get as granular as we were when we had full access to both healthcare systems. But there's a lot of information in these common data models. So for example, PCORnet has clinical research networks with health systems providing care to more than 47 million patients a year. And the common data model includes a lot of these different components. So we can get things like conditions, procedures, claims, patient-reported outcomes across a variety of systems. And again, happy to answer questions about it at the end. So I'll finish up with some takeaways and resources in our last couple minutes and then open it up to questions. So I know I threw a lot of information at you all, and I wanted to cite a paper at the end that has some of this really written out. But one to start and end us with an AI generated visual, citing Huan-Yi Hong at Duke, who has this metaphor that's in our paper that just came out, where you can kind of think of the RCT, the randomized control trial, and a causal question specifically as the greenhouse in this visual, and electronic health records as the more uncontrolled outside environment. I don't know if the level of messiness in this picture is exactly appropriate. It probably depends on the study, but we can think of these two types of studies in different ways. And with the EHR, we might have more flexibility, less control, and that can be both a pro and a con. And I hope that today you got some of the different components that are important to keep in mind to try to, going back to the very first picture, kind of get your data into a clear final picture. And then I mentioned throughout several biases to keep in mind. So I just wanted to have these listed. And again, not just to list the problems, but to keep in mind some of the solutions and the fact that addressing these can really improve your study design. So these are all listed here. And in the interest of time, I won't re-go through all of them, but it's important to keep in mind, again, factors like observability. So keeping in mind who's coming into the healthcare system, and that's not random, who's getting treatment and why is also not random. And then measurement error can occur. So that's all some points I wanted to have. Sensitivity analyses can help to address these biases, can help to address some of the most challenging decisions that you're making, like looking at multiple outcomes or how you defined your cohort, can be explored through sensitivity analysis. And then again, since I felt like there's a lot of challenges, I really wanted to hone in on the fact that EHR work is really interesting, fun, informative, and gets at really what's happening in real world care. And the best data source for a study can can change. So depending on your particular work, again, we used multi-site EHR and particularly two EHRs that we had full access to, not using more of a common data model type approach. But if you're trying to look at really rich clinical data within one system, one EHR can be really effective. Claims data, of course, are another world and are strong for utilization, longitudinal coverage across systems. Multi-site or network EHR can also look across systems, sample size diversity can improve, but it also kind of, in the multi-site case, can increase heterogeneity across your sources and how things are defined. In the network sources, that has been addressed through harmonization, but that can limit kind of the full access that you gain. And sometimes none of the above. Sometimes there's other types of sources that can be effective. And then I wanted to mention the importance of the multidisciplinary team. So in this case study, we have a lot of people, and I have some acknowledgments on the next slide that don't even touch on everyone that's been involved in these studies. So I come from a biostatistics background, but really to be able to do this effective work in mental health or in other areas, it would be really limited if I didn't have the clinical collaborations and expertise, the patient partners, kind of the understanding of what is a doctor's perspective when they're working with the healthcare system and what's a patient's perspective and how does that get reflected in the data that we see. And without those conversations, I think it'd be really limiting from kind of a statistical or data engineering perspective. And so there's a lot of other topics listed here and more that are not listed as well. But in general, working on EHR requires the multidisciplinary team and is so helpful to have. Okay, so maybe I'll quickly go. I wanted to acknowledge Liz, many others who I mentioned, and our funding that funded some of this work with the case study that I mentioned. I have my contact information listed here, and then I'll also go back a slide to show a few resources. So this is the paper I mentioned and the DOI. This is particular to integrating trial and electronic health record data, but a lot of the components that I talked about today are relevant here. And then this is some other work in EHR that I've touched on throughout. And down here, some real world data networks that are helpful if people are trying to look into ways to look at multi-site EHR. All right, and so that is it. I have not been looking at the chat. Thank you all so much. And Liz, I'll jump to you to see if questions have come up.
Fantastic. Yes, that was great. And one of the not questions, comments that came up was how well organized and helpful this was. Actually,
Oh, good.
now, oh, we got just one. I'll just read it to you. This was a superb presentation, one of the best organized and most informative lectures I've heard in a long time.
Oh, that's so kind. Thank you.
So thank you for this. It was great. And yeah, there were some questions that came in, and I've kind of mentally, anyway, I have a few that I'll pose to you. And I think actually many of them are essentially like you had like a bullet and it's sort of wanting to dig in a little bit more because, of course, you couldn't cover it all. So maybe the one I'll start with is there's two that are related, I think, but I'll start with this one, which relates to like two slides ago where you were commenting like, oh, you can use claims or you can use EHR. Yes, perfect. And I think, this is one of the things I was going to ask about too, is sort of a little bit more on like your experience of what sorts of research questions are best for different sources. And in particular, so Phil Miller asked, can you discuss the pros and cons of doing EHR research within your own institution versus using data from one of the networks? So maybe I'll broaden that. If you could just give a couple examples maybe about sort of internal, one institution, the networks, and then maybe I'd also throw in something like also compared to say claims data. And because you and I have talked about that some, so I'll stop there and just see if you have any, could you just sort of talk about that a little bit more?
Yeah, it's a great question. And I think in my experiences so far, I feel like it started to become clear, like depending on the research question, and depending on the limitation. So one big thing when it comes to network data versus one EHR is things like budget. So if you're working with PecorNet, if you're working with other sources, a lot of times those require budget. And so if I think a single EHR can be really effective for like starting points of questions. So for example, I mentioned at Duke in the OB/GYN department, we're trying to look at patient-provider communications and looking at transcripts and trying to see like, can we better identify patients with certain conditions that maybe aren't captured from codes, like the structured data. So that type of work that feels more preliminary, it feels like we really need to get rich detail, and our resources, like we want to get at transcripts, that feels like one EHR is the clear answer. Like we have to start with one EHR and we want to get really granular. Um, some questions that are more like large scale comparative effectiveness or trying to maybe we've looked at something in one EHR, but we want to see how much it applies and how much it generalizes across the country. That's where bringing in multiple EHRs using the network data is really effective. A lot of the work that I do with network data here at Duke, we do a lot of prospective actual work with the EHR. So, for example, a study, this is in pediatrics, but trying to look prospectively at pediatric patients and comparative effectiveness of a couple medications for inflammatory bowel disease. So, not in the mental health context, but when we're trying to look prospectively and look across the country at a generalizable result, that's when the network data really is helpful for recruitment and for identifying people across the country. So that's kind of my thoughts around single healthcare system versus multi. So it's a little bit resource dependent and it's also dependent upon how granular versus how generalizable you're trying to kind of weigh those different things. And then claims, I mean, I haven't done a ton of work with claims. I'm doing a little bit now more trying to get involved in the policy space, like trying to look at insurance, but I would say they're very strong for coverage across systems, utilization, but maybe a little bit less helpful when it comes to the more like very nuanced clinical experiences and symptom severity, things like that. So again, I would say I'm relatively a little bit less experienced in that space, but that's been my understanding.
Great. That's super helpful. And now there's two questions that I think actually continue to dig into this in a little bit more like sort of specific pieces of this. So I think I'll do this one first, which is actually it's a topic you and I have talked about and sort of the tension of wanting the cohorts to be similar to the RCT
Mm,
data, but yet that actually kind of negates potentially some of the value of the representativeness of the EHR. So the question is sort of the routine practice, and like in randomized trials there's often all these exclusions, and so we know that the people in the trial are probably a very specific group. And so then the question is sort of like if we make the patient population like this tension of wanting to maybe make our EHR sample like the trial sample, but if we do that, then in some ways we're losing the benefit of having the reflection to routine practice. So again, you and I have talked about this, and maybe I'd ask you, since I know a little bit about this, if you could sort of touch on the decisions we made here and expand on that, but then also kind of why and how in my mind, some of the points of the original research we were doing here helped motivate why we did it that way, but maybe just reflect on that a little bit more.
yeah, it's such a good point, and it is something we spent a lot of time on. I would say I don't ever want to lose the benefit of the EHR. And one of the big benefits of the EHR is that you don't put these same restrictions of a trial. And so I think when you're looking at causal questions in the EHR, like this cohort that I presented where we went really like narrower, where we went from patients with depression and these treatments and then all the way to like restricting their baseline depression, removing comorbidities, things like that, the reason why we did this was to be able to get really close to what the real trials did, and say, like, if we were to do something super similar in our EHR, how would we construct that to match the trials? But I would say, if given like the fact that you probably don't want to do 20 different cohorts in one study, going this granular feels like it's not as helpful and it takes away the real power of the EHR. So I will say I have liked I know others might disagree. I think there's different thoughts on like what level of sensitivity analysis to do, but my perspective has been that exploring the strengths and downsides of your cohort construction decisions can be really helpful to do through sensitivity analyses or through kind of exploring multiple cohorts, having a primary and then having like an exploration of what would happen in a secondary cohort. So I think looking at multiple options is effective, but I would say I lean towards trying to use the EHR's power, especially if there's a comparable trial. Another thing I'll say is if there is not a comparable trial or this is the first thing you're doing and you really want to get granular, that's also a very fair motivation. And feel free, I don't know if you have things to add on that too, given our conversations.
No, that was great. Yeah, I think it is. And just to reiterate what you said is, and this relates to some of the other questions that came in, is like, A lot of this is just thinking really carefully about the purpose of the study you're doing and then sort of making decisions aligned with that, and that there's not like one right answer for how to do an EHR study. So I'll leave it there. So another question that again sort of digs into a little bit of some of the limitations is, and again, you sort of alluded to this with like, this is one difference with claims. How do you handle the possibility that care outside the Hopkins Duke EHR might involve one of the studied drugs? Or I would go broader again, we've talked about this, like especially in mental health, people are often getting care or, might be getting care from Hopkins and then also from the University of Maryland, or, sort of we see what they're doing in one system, but with EHR data, we don't get to necessarily see outside of that. So the question was, is it just a limitation or are there ways to handle it?
Yeah, it's a great question and something that I feel like with every study it comes up again and again, and there never feels like there's a fully right answer. That is where, like if you're using an Epic Cosmos or a PecorNet, or you're trying to get more network wide, that's where you can try to get more confident that you're capturing more full pictures or claims. But even with some of those data sets, you sometimes can't be fully confident. So I think it's always a challenge. I think what I mentioned about follow-up and the idea of censoring is one potential idea where if you're in a clinic or you're in a healthcare system or in a condition where you feel really confident about the amount of follow-up time that's acceptable and someone's not coming back at all, like for example, this is again not in mental health, but we're looking at a pregnancy cohort, and we feel confident about when someone should be coming back. So if they're not coming back in that time, it feels like a censoring approach could be appropriate. But if you don't have kind of an expected trajectory, I think when you're looking just within one or two EHRs, it sometimes does end up just being a major limitation.
Thanks. Yeah. So I guess, right, one kind of to expand on what you said, part
Yeah.
of it might be defining your research question carefully, defining the cohort carefully, and maybe there's ways to try to at least sort of look and try to set things up in a way that this would be less problematic. But it is something I've thought about, and I think is one of the differences. Different conditions are going to be very different in this regard.
Yeah.
Someone with certain diseases might be, cardiologists, they might go to their Hopkins cardiologist all the time. In other disease conditions, it might be more of a problem. So to me, this is also just one of these points where the statistics and sort of the study design can't be done on its own, like the multidisciplinary team you referenced. And again, there's not like one right way to do things. Different areas, different questions are going to have different sort of considerations.
Yeah, completely.
Great. Okay, I'm going to now switch to two questions about the free text data, because in some ways this is really one of the potential benefits of the EHR is having the clinical notes. And I want to read this one because it's particularly interesting given the person's background. So this questioner said they were an academic family doctor for 30 years and a statistician epidemiologist for 15. So they say, I go back to the pre-EMR era when we actually wrote things, and agree that written clinical notes can be very rich in information depending on the clinician. But he wonders if the sort of medical record boilerplate text, which Epic calls them dot phrases, are as rich, where it's sort of, maybe more just like, this is like my kids' report cards where there's literally like, you can tell there's like 5 choices of what to say about like good in class, whatever. So sort of just maybe Gail could even chime in here of just sort of how much is there really in the clinical notes, and how do we sort of use them well, or kind of just account for that, and how do we even maybe study that over time, and especially because they might be evolving. Of course, this doesn't, I'm actually now editorializing with ambient AI in the exam rooms and in provider visits. This might also be a whole other thing where soon we will have actually like just the recording of the whole visit. So I don't know, maybe Carly, see if you have any reactions, and then I'm glad Gail is here and can chime in.
Yeah, that's great.
Yeah, I mean, I'm excited to hear your thoughts, Gail. Yeah, I guess I would say it's important a couple things came up there. One is like knowing that provider norms can differ. So like some providers are going to give more notes than others. And I do feel like there's a little bit of a tiering of like, okay, what can you get from the structured? What can you get from maybe these dot phrases? What can you get from detailed notes? And then what can you get from transcripts? So that's kind of the second column here is like if we had basically everything, what can we get? So I would say I don't know if I have a generalizable answer to the difference. And I'm excited to hear about the mental health context. But I will say an ongoing study in OB-GYN that we're doing is like answering this question of how much better is our cohort and our covariate definition when we bring in each additional piece of more detail.
Yeah, so I mean, I think this is really fascinating. I think that certainly on the inpatient side, people tend to copy kind of kind of these templates day after day or copy from other consultants and things like that. And so I think given the burden on providers, we may be seeing less complex or less, I don't know if it's less detail, less nuance in the notes than certainly when I was training and early practice where we wrote everything out. I do think that um, adding in the transcripts of the visits will add a completely different level of detail and contextual richness that will be really, really interesting to study. And I think that will benefit our our studies that we're doing with electronic health record data. Those will be very valuable. I do think also it does provide us an opportunity separate from like whatever clinical research question is at hand to study how these are changing over time. So, but I do think it's also important, whatever practices you are doing the study in, to kind of have some context from the providers there. I mean, I guess if you're doing it nationally, it's too hard, but if you're using a few EHRs to kind of know what their note templates or their note taking is like, so that you can know what to expect from what you're seeing in the unstructured data.
Great, thank you. Again, a nice example of the multidisciplinary part right here in the webinar. Yeah, and Carly briefly referenced this, but we're doing some work on this clinical global impression scale. And Gail, to your point about copy paste, one of the things that the LLM, large language model, was having trouble with was that it was having trouble sort of identifying which part of the text related to kind of current state versus just the sort of summary. And especially when it was sort of, we were trying to get at like current, but there'd often be a lot of like historical background, sometimes clearly cut and pasted. And so, yeah, I think figuring out how to, in an automated way, how to make use of that in reasonable ways takes a lot of care.
Yeah, like what's the note on that day, like that visit,
like what's relevant for the current
summary
day
from the
versus,
past 2 weeks.
Yeah.
Mm-hmm.
So lots of, part of this webinar overall in this series is to identify, and I know there's a lot of statisticians on the call, good question and research areas. There was another question I'm realizing after the fact it was related. I think we've heard it about the loss of nuance, phenotyping and outcome assessment. So maybe I'll go, I think then one more but if anyone, feel free, we have a couple more minutes if folks want to add an additional question. This one's a little bit more specific but I think getting into it would be nice to convey again sort of the specificity and the sensitivity analyses, which is that and it relates to another one that came in around the other question was about, it's sort of the timing of a diagnosis, so say an ICD-10 code and the medication use, and especially in depression, there's often long clinical courses, changing diagnoses, depression, bipolar, sort of kind of on and off. We were anchoring on the medication use as our sort of time zero and sort of that clinical question. In other contexts, it might make sense to anchor on the diagnosis itself. And so the question partly there was a general question about that, but then also that creating sort of the timing windows between these can be difficult. And, do you rely on subject matter experts, sensitivity analysis with multiple windows? If someone had a depression diagnosis 5 years ago, how do we think about that? So yeah, this is a perfect slide for you to talk that through a little bit more.
Yeah, and so I think this is again where the multidisciplinary team is huge. So like I if Gail or if either of you have thoughts, I guess can you so the question was basically like what do you do if you want to anchor on a diagnosis? That diagnosis can be messy.
Yeah, and also like when a diagnosis and the sort of medication might not be aligned
Yeah,
time-wise.
yeah. Yeah, I mean, yeah, like you flagged sensitivity analysis, like I would say here is a great example of where, okay, without this anchoring on a diagnosis for our medication, we had 13, 14, 15,000 people. When we anchored on it, we cut that in half. And I don't th I mean, not the clinical expert, but I wouldn't expect that half of the people were getting these medications for other reasons. Maybe it's a little bit, maybe some of the people are, but I would say a lot still are getting them for depression. So that's where kind of exploring how sensitive your results are to these different choices is helpful, and that's what we did. We looked at the differences, and from my memory, we weren't seeing like substantial changes in our conclusions, which was helpful to see. But yeah, when it comes to kind of anchoring on a diagnosis, that's where I'd say a look back period is helpful. Just like we did here, where we said they shouldn't have had a prior prescription. Maybe we can use a look back to say they shouldn't have had a prior diagnosis. I would say in mental health, for example, it can be especially challenging, like you said, Liz, because there can be a lot of different trajectories. Another attempt could be to look at something like PHQ-9 to measure kind of severity, but that is highly missing. So I would say that with a lot of hesitancy. But I would say the look back period is something that can be used regardless of whether it's a prescription starting or a diagnosis starting.
Great. Um, so I don't see any more questions. Maybe I'll just we can end. We can give folks 5 minutes break, but let me end with just a big picture kind of final question, and we'll see if another one comes in. What advice, there's a couple people that posted, oh, this was so helpful because I'm going to be starting a study, and do you have any like a couple just super high level pieces of advice you would give to people who are starting to wade into the use of EHR for these research questions?
Yeah, that's such a fun question. I would say biggest piece is get a good team. So find kind of where your expertise, like again, I know I'm a biostatistician, and so I know that I cannot do a study around this without having clinical expertise, knowing someone who's actually inputting data. So not just working with a maybe someone who works with the EHR on the back end, but working with someone who inputs data into in the healthcare system. So I think that has been so important. And I would say also knowing that things might take longer. I mean, I think this is true with research in general, but I think you can have a cohort in your head, but there are going to be so many little questions that come up that take a meeting and take a conversation. So I'd say making sure to be really particular and knowing that actually all of those decisions, they're not just like annoying things to have to adjust, they're actually make an impact on your result. Like I know I showed that picture at the very beginning. Really, those decisions can change the final picture that you get from the study. So, yeah, I would say multidisciplinary team, keep in mind that the little questions and little decisions do matter. And I would also say exploring different outcomes, I do think is interesting, depending on your study, but knowing that maybe a particular outcome that you've had in your head or you might do in a trial might not match what you can get reliably in the EHR. So exploring different outcomes can also be helpful. And I could go on, but I'll stop there.
That's fantastic. Thank you, Carly. This was great. Again, I think even the exchange highlighted the interdisciplinary nature and the importance. So, thank you all. Thanks for joining us today, and we hope to see many of you back in March for our next session. Thanks so much.
Take care. Thank you so much.
Bye.